What are the neurological causes of ptosis?
Eyelid ptosis, or drooping of the upper eyelid, is most commonly caused by stretched, detached, or a dystrophy of a muscle that lifts the eyelid called the levator muscle. The word levator is like the word elevator, but without the letter E. In addition to these common causes of ptosis, which are generally limited to the levator muscle, there is another category of ptosis called neurogenic ptosis. Neurogenic ptosis is a condition where the cause of the eyelid droop is related to the nerves which send signals to the muscles that determine your eyelid position and function. As is important in all areas of medicine, an accurate diagnosis is critical to a successful treatment strategy. I'll discuss different causes of neurogenic ptosis and the ways these conditions may be addressed. I'm Dr. Amiya Prasad. I'm a diplomate of the American Board of Cosmetic Surgery, and I'm a fellowship-trained oculofacial, plastic, and reconstructive surgeon. I've been in practice in New York City and Long Island for more than 25 years. I specialize in eyelid ptosis correction surgery, such as levator muscle advancement for age-related ptosis, and levator muscle resection and frontalis sling for congenital ptosis. I also specialize in performing ptosis surgery from behind the eyelid, such as Mueller's muscle resection. This particular approach allows for expedited healing since no external incisions are made if there isn't any extra skin in the front. In the cosmetic field, I've recognized for years that eyelid ptosis is frequently overlooked when cosmetic eyelid surgery is performed. This oversight can result in the patient still looking tired despite having undergone upper eyelid blepharoplasty. In my practice, I routinely perform ptosis surgery for patients who come for cosmetic eyelid surgery to help my patients' eyes look brighter and less tired. When I'm seeing a patient who has ptosis in my office and I suspect a possible neurologic cause, I generally think about three conditions. One is myasthenia gravis, two is Horner's syndrome, and three is third nerve palsy. Briefly, myasthenia gravis is an autoimmune disease characterized by weakening and fatigue of muscles in different areas depending on the type of myasthenia gravis the patient has. Myasthenia gravis can also affect the muscles responsible for eye movement. This means that in addition to eyelid ptosis, because of the coordination loss between the two eyes, the patient can also experience double vision. Horner's syndrome is the disruption of nerve pathways from the brain to the eye, affecting one side of the body, which can result in eyelid ptosis. Horner's syndrome is most often associated with conditions such as stroke, spinal cord injury, or the presence of a tumor. In some cases, no underlying cause is determined. Horner's syndrome also affects the eye, where the pupil is small and doesn't open under low light conditions. In addition, there is an absence of perspiration on one side of the face. The triad we're taught in medical school regarding Horner's syndrome is ptosis, meiosis, and anhidrosis. Since Horner's syndrome is most often caused by another medical condition, treatment is most often focused on dealing with the underlying cause prior to any eyelid procedure. Third nerve palsy occurs when the third cranial nerve, also called the oculomotor nerve, has been compressed or does not get adequate blood flow or blood supply, affecting movement in the upper eyelid and the eye muscles. In addition to ptosis, the eye is misaligned, so it appears to be looking down and outward. The sudden onset of this condition can be a medical emergency because of the possible presence of a brain aneurysm. In my practice, if I see a patient who I suspect has a neurogenic ptosis, I work with a neuro-ophthalmologist to perform the full diagnostic workup as well as manage any medical-based treatments. Once this is completed, I'll perform the appropriate eyelid ptosis surgery. We perform eyelid ptosis surgery with local anesthesia and light IV sedation. In some situations, I'll perform surgery and actually have my patients sit up to confirm successful elevation and symmetry and contour. Patients go home the same day as surgery and return to work in 1 week or less, depending on the type of ptosis surgery that I performed. In conclusion, it's important to diagnose and manage neurogenic ptosis appropriately. Once appropriate medical management is completed, ptosis surgery is performed to help people see better and look better. I hope you found this information from my experience helpful, and thank you for your question.